Okay, good evening, everybody, and welcome to another hashtag What's Next here on Open Dialogus. And thank you very much for joining this. And I can see you joining in your numbers. Do me a favor, make sure that you share this and get as many people as possible to either watch it live or to watch it on replay. But either which way, you're all very welcome to the stream, as indeed are my two special guests. Now, both our guests tonight, they're no strangers here to Open Dialogus. And I mean, of course, Godfrey Bloom and Rebecca Butler, who join me for this special 1-hour debate on what I would say is COVID-19 getting behind the numbers. And this will all become clear to you. So that's the headline topic. And just a quick introduction. For those who don't know Godfrey, and I guess lots of you do, Godfrey's, as I say, he's a friend of the channel. But let me tell you a little bit about Godfrey. Godfrey finished his city career as a CEO of a life assurance company and a research economist for an actuarial practice. His groundbreaking, if unfashionable, research papers exposed misinterpretation of data on dairy products and cholesterol, HIV and passive smoking. They were considered eccentric in the late 80s and 90s, and today are quietly accepted as mainstream. He's a self-confessed slave to numbers, not emotion, and has won international prizes for fixed fund management and is a successful Austrian school economist author. Welcome, Godfrey. For those who don't know Rebecca Butler, let me tell you a little bit about her. She is in order of priority, Rebecca, and you will be familiar with these words: mum, dog owner, golfer, cyclist, skier, sailor, ex-nurse, and barrister, and a centrist. She's also a big Gary Barlow fan, but never mind. Rebecca also works as counsel with the Free Speech Union and has been a strong voice for Brexit over the years. And a warm welcome to you, Rebecca, as well.
Hello, David. Hello, Godfrey. And welcome to everybody on the stream. And Jed, you've done it again. Well done.
He always does, Rebecca. Okay, folks, let's start our conversation and see. Let's start off to see if we can agree in numbers, okay? And just a little preamble for me in this one. I wanted to start off with the ONS summary for 2020. Now, this is from mid-December, and in mid-December, they stated that there were a total of 82,957 deaths taking place up to that date, where COVID-19 was mentioned on the death certificate. They added that by the end of December, so about a week or so ago, there will have been around 83,000 deaths involving COVID-19 in 2020. And in about 9 in 10 of those deaths, so 90% of those deaths, COVID-19 was the underlying cause of death. And in the remainder, COVID-19 was mentioned elsewhere in the death certificate. Now, 90% of 83,000, I estimate as being 74,700, according to my calculator. And that's pretty catastrophic, I reckon. However, and this is the strange thing, folks, if we focus on those with no pre-existing conditions from March to June 2020, there were 4,476 deaths. So this is confusing. Rebecca, let me start with you. How many people died from COVID in 2020?
I think the current estimate in broad figures is 70,000, where COVID was mentioned on the death certificate. Where I take issue with the summary you've just given is it is in fact a misrepresentation of the numbers. 4,500 people have died without any other comorbidity. So it's almost like a bomb going off in a football stadium. 4,500, roughly speaking. I think it's 4,700 just died in the bomb blast. There's no comorbidity and no other reason for them dying. What I think people quite often misinterpret when they are talking about the numbers in these terms is that that is a lot of deaths. That one big bomb blast is people like you or me who have got no other underlying conditions. That is a major tragedy, and that is a worrying number of itself. It's not that number that justifies locking the country down, by the way. The big number is the 72,000, and a lot of those deaths are accelerated by virtue of COVID-19. So the reason they're on the death certificate is because it is under WHO rules a notifiable disease, because it is in the pandemic protocol. And so it has to be on the death certificate, because we need in the future to be able to do health monitoring and to know what the problems with COVID are when you deal with cancers or cerebrovascular diseases, kidney diseases, liver diseases, and so on and so forth. When you say no other comorbid conditions on the death certificate, by the way, that can be something as simple as hypertension or type 2 diabetes or, you know, some chronic skin condition. So, you know, you're talking about otherwise healthy people are dying from this disease, and you can't get away from that. So solely dying from COVID, even 4,700, if that was a bomb blast, you'd think that was a pretty big event in the country this year, and that's just in the UK. So I don't think you should minimize that number in the way that you have, actually.
Well, actually, well, okay, Rebecca, push back on that. I was quoting specifically from the ONS. If I put the word only in, I apologize, because obviously, and I'm sure we'll all agree in this, the death of any person, you know, is obviously a tragedy for the family, and that's goes without saying. I was just trying to understand how many people died from COVID. It's a really simple question, Rebecca. You're saying around
from COVID, David, I could escalate that number quite high, because I would say people who die from COVID are also the people who die as a result of the pandemic and as a result of lockdown. And we won't know those numbers for a very long time. But all-cause mortality between March and June was in excess of 76,000 more than last year. And I would say that those are the cancer patients, the other chronic diseases, the early diagnosis and undiagnosed people who didn't make it to hospital, of which 32,000 died at home, more than last year. So that is dying from COVID. That's dying as a direct result of the pandemic, whether they actually caught COVID or not. The pandemic has caused masses of early deaths, for sure.
Okay, Godfrey, how many people died from COVID or of COVID in 2020?
Well, this is the problem, you see. I speak as a sort of an assessor of risk in my professional career for many years. And we don't have the numbers to assess because we've removed all the protocols in the death certificates. So we don't do death certificates like we used to do them. They're a little bit on the back of a fag packet. So for a professional assessor of risk like myself, I can't make any serious judgment on how many people have actually died of COVID, nothing else. Look at the Office of National Statistics, and I can look at the Public Health England figures, and that in cold, bald terms would tell me that round about 80 people have actually died with only COVID on the death certificate. Now, with comorbidity, as Rebecca quite accurately says, it could have been diabetes too, or it could have been something relatively low risk, or it could be like my friend who died 2 weeks ago of pancreatic cancer, and he went into hospital. He was tested positive with COVID, and COVID went on his death certificate 4 days later. Now, we all know, everybody watching this will know that this is happening all over the country. So when you say who is actually died alone, the answer is we simply don't know, because we've abandoned death certificate protocols, which I think is a terrible shame and makes me very suspicious of numbers. So we don't know. But if we look at excess deaths, let's have a little look at excess deaths here. Yep. And look at them in retrospectively. Now, as a professional, I can't look at the last few years, because that's not what I do. That would be like looking at the stock market and extrapolating the growth. If the stock market grew by 10% in the last, a mathematical model would tell you that in 4 years' time, the stock market is going to double. Life isn't like that. It doesn't work like that. What you have to do is you have to go right back if you want to judge what statistics are in mortality statistics. And I do this for a living. Well, I used to do this for a living, okay, for many, many years. You have to go back to 1957, 68, 69, 2010. You have to go right back for at least a generation to find out who's dying and how you can actually assess this. And if we look at excess deaths at the moment, we know, for example, they're around about exactly the same as they were in 2010, and significantly less than 1957, 1968, 1969. So the question is, how serious is this problem? How serious is it when we are actually locking down the country completely, and we are throwing our society and our economy out of the window, and we are now have actually fewer freedoms than North Korea? So the baby's gone out with the bathwater. So yes, it's a serious problem. COVID's a very nasty bug. But what we're dealing here is one of the most appalling overreactions statistically that I've ever seen in my career, and I'm 71.
Well, Rebecca, would you agree it's been an overreaction, as Godfrey suggested, or do you think that actually it's entirely proportionate with the numbers?
Well, first of all, I would take issue with what Godfrey refers to as excess deaths, because you have to age standardized mortality when you're looking at the statistics. And without wishing to get too deep for the purposes of this discussion into it, you can't compare 1957 with 2020, when our life expectancy has gone up and our general health care has improved dramatically. Even the infection fatality rate of COVID has dropped over the course of 10 months. So I don't agree that you look back as far as 1957. I think you should look back 3 to 5 years. And I've always said that the true cost of this pandemic will not be evident for another 5 years or so, because of the onward problem of people dying early from cancer. Where I take another issue with Godfrey is how he quotes the death certificate of a friend, and I'm sorry to hear about his friend dying, but it really matters, Godfrey, where on the death certificate the COVID was put. Was it at 1A, 1B, 1C, or was COVID present? Now, have you seen the death certificate, yes or no? Because if COVID was tested in your friend, it must go on the death certificate. That's not fraudulent, that's not aberrant, that is entirely correct, and that is a methodology that we have had since the AIDS epidemic of 1984. So there's nothing aberrant about it. Where the aberration has occurred this year is because GPs were not going into care homes to certify deaths, and the senior nurses in the care homes were having to call the coroners to get authorization for what had to go on the death certificate. And the guidance in March, which was changed in July, the guidance in March was, if there is COVID-19 in the care home and the patient has died unexpectedly early, you must put COVID-19 on the death certificate at paragraph C, not 1A, but paragraph C. Now, your friend probably died from clotting disorder or any of the other problems with pancreatic cancer at 1A, 1B pancreatic cancer, C, COVID-19 present. It's entirely right that we do so, because we need to know how COVID-19 accelerates deaths. So although it would be an anticipated death with pancreatic cancer, it could have been accelerated by COVID. And this is something we've had in place, as I say, since 1984. I don't see it's contentious at the moment.
Godfrey,
I would argue that it certainly is contentious, because I think that protocol that you mentioned, and I don't take issue with it, Rebecca, at all. You're perfectly right, and I understand that. But you will find in the political and mainstream media arena, it is not put across like that. It's put down as a straight number. And let me pick you up and say, not going back to 1957 or 1968 or 2010 even. Yes, there has been improvement in medical care, so on and so forth, which I don't dispute. But what you've also got to understand, of course, is that there is a significantly older population now than there was then. The natural ages. So we're trying to compare apples with oranges all the time. However,
which is why the age standardized mortality.
Well, I would argue, you see, we're coming back to the same problem, the same question mark. And I'm not alone. This isn't just Godfrey Bloom here. We've got the University of Bristol. We've got the Institute of Actuaries. We've got all sorts of Harvard Medical School. They're all saying the same thing. This is not the way to deal with this situation. We also know, of course, do we not, the lockdowns don't work. Everybody knows the lockdowns don't work. If they worked, we've had one lockdown, two lockdowns. We've had with masks, without masks. Tier 4 is virtually a national lockdown. The point is, if you look at some of these universities, and if you look at the evidence-based medicine at Oxford University, if you look at all these institutions, they're actually saying that in years to come, or even months to come, we're going to find that lockdown itself creates excess deaths. And they're up to 50%. If you take Oxford University and some other very respectable people and institutions, they're saying this is actually accelerating deaths. Whether you go 1A, 1B, or 1C, which is a nice point of interest, and you're a professional and so am I understand that, but that really isn't the point when you lock down the entire economy, which we didn't do in 1968. And nobody can conceivably argue with me that 1968 was significantly worse than it is now, and we didn't lock down the economy.
Yeah, so the issue is that this is why I never ever discuss the justification of lockdown on death numbers. And David Vance will confirm that I'm always very, very uncomfortable about discussing this in absolute terms of death, because of actually, you and I pretty much agree that the recording of death, particularly when you're in a pandemic protocol, is different. There are too many variables thrown into the mix to be able to give you a good baseline from which to calculate the true number. And I never, ever discuss death rates for precisely that reason. And I will always defer to somebody with your knowledge on statistics when discussing death. I don't disagree with you, and I am 100% behind you when you say that lockdowns cause more harm. I say they are measurable down the line. I think you and I would agree with that, because people don't die immediately from cancer. They die from reduced survival rates from delayed diagnosis, for example, and the same applies to other chronic diseases. I never talk about death rates for that reason. I justify lockdowns on the basis of the reduction in hospital admissions. And that is really the only metric that I use to have these discussions, because of the problems you've highlighted with recording deaths.
Well, actually, can I just come in here, Godfrey? Actually, this is for you, and it's kind of following on from what Rebecca said there. You know, we've seen in the news in the last number of days these reports that NHS hospitals do face being overwhelmed by COVID patients unless something dramatic is done. And the something dramatic that is being done, which I think Rebecca, broadly speaking, thinks has to be done, actually, is lockdown. So the question for you, Godfrey, is, you know, are you prepared to see NHS hospitals overwhelmed then? And do you think that would be good for the nation's health?
I need to answer that in 2 points. We know that the virus is aerosol driven. We know it's in the air. And I'm a country boy. I can assure you that when I walk the dogs for a mile or two in the spring, and they are spraying maybe a mile away their crops, I can smell that. It can travel miles. This idea that somehow if you keep 6 feet away from somebody, or you wear a sort of a face nappy, a piece of cloth, is actually going to stop the transmission is fundamentally ridiculous and absurd. So let's put it this way. There's nothing you can do about this. Once the virus is out of the bag, it's out of the bag. And all senior independent virologists agree with this hypothesis. It's out of the bag. There's nothing you can do. There's nothing Boris Johnson can do about this, or Matt Hancock can do this. There's nothing NHS can do about this. So that's point one. There's nothing you can do about it. It's out of the bag. Now, point two, that are the NHS going to be overwhelmed? Well, that's not what the numbers tell me. And I'm a boring sort of chap. I just do numbers. And when I was at Sandhurst many years ago, when the British Army had bows and arrows, the one at the beginning of the course, for goodness sake, never actually tell the DS staff at Sandhurst that the map's wrong. The map is never wrong. It's your interpretation of it. Now, I've got the figures in front of me for the so-called pressure that the NHS is under. Let's just talk about ICU units in London are 7%. So they're getting stretched. They're being pushed 7%. But for the rest of the country, it's 70%. So the NHS isn't under pressure. Otherwise, if it was under pressure, why did they get rid of the Nightingale hospitals? Which begs another question. Is this really about health? Is this really about the NHS? Or is it about something else that we're not being told about? Because the numbers don't make sense. The NHS, and I've got so many friends in the NHS. I mean, my wife is ex-NHS. I've got surgeon friends, radiographer friends, and they're telling me there is not pressure on bed spaces. There's not pressure on bed spaces. And even ICU units, it's only in London. So what is the truth? We're not getting the truth here.
Well, Rebecca, what's your interpretation? The news reports do say that the NHS is going to face severe stress. Godfrey's suggesting that, experience suggests that's not the case. So what is it?
So I looked in preparation for this, I looked at what they call the heat map today, and the heat map is published by the Health Service Journal, which is the journal for health service professionals. Excuse me. And the heat map says that 30% of all hospitals, 20% of hospitals trusts in the NHS are operating at 30% or more COVID patients. So 30% of their beds are taken up by COVID patients. Okay. The highest one in the country has 67% COVID patients, and that's the Middlesex Hospital. So that's a North London trust. That does not include ICUs. ICUs currently have 2,000 patients with COVID. That is out of a potential 5,500. So just over a third are occupied by COVID patients. What I think it is hard for people who don't work in the NHS to understand is that nursing COVID patients on the ward requires more room, more nurses, and more time to put PPE on and off, because nurses cannot move around between patients with PPE. They cannot spread the infection around. The bed numbers have been reduced by 10% purely by virtue of the distance required between the COVID patients. You then look at ICU, and the ICU situation is so dire now that the surge capacity has been used up. The nursing ratio on an ICU bed has gone from 1:1 to 1:3. Now, I speak about a member of my family, very close member of my family, who's a consultant ITU at Southampton. They are at 150%. They're using theatre recovery areas to nurse their ICU patients, and they are shipping their patients out to Sheffield. Coincidentally, my daughter admitted his patient in Sheffield. That is how close this is to my family. The northern hospitals are taking the overspill from the south and the southeast and London hospitals. The other point to make is that When I say that so blandly, it sounds really easy. The risk of death to a patient from simply putting them into a helicopter rather than keeping them in their ICU bed is massive. Many people die in transit. It is a task that you don't undertake lightly. And we have at least 12 patients per day, per trust in the South Coast are being moved on a daily basis. This is a terrible, terribly dangerous thing to do. And the ICU capacity is a major issue. It is not simply a bed. It is not simply a nurse or a quarter of a nurse as it is now. It's technicians, it's ventilator technicians, it's nutritionists, it's biochemists, it's microbiologists, it's anesthetists, it's the whole array of professionals needed to care for an ICU or an HDU patient. It is no mean feat to upscale any of that.
Godfrey.
Well, I warned of this 6 months ago. I wrote an article in the magazine Going Postal, and I warned of this. I knew that there would be a personnel problem, not a bed problem, all right? And you're quite right. I agree with everything you've just said. But now here we have, and we're bound to get onto it sooner or later, a testing system which is absurd, clearly absurd, doesn't work, not fit for purpose. But we have a 10-day cycle of self-isolation. And what actually means, and I worked out and I came very close 6 months ago, because I'm trained to look ahead. I'm not reactive. I like to be proactive. So what have we got here? You can have somebody, and I've got a whole ream of stuff here as well, from personal connections, and people write to me and feed me information from hospitals. There are doctors and nurses and technicians and anesthetists and all the rest of it who are on 10-day self-isolation, who've had the jab, who have absolutely no symptoms at all. There is no evidence that if you have no symptoms whatsoever, it's transferable. And you also just mentioned, I don't quite know why you would say this, if you're all COVID, suffering from COVID in the ward, why would you need that much extra bed space? Because, you know, I know you need machines and you need respiratory things. I know you all need all that, but I would suggest that the actual physical space, but that's not the problem that we have. The problem we have is there are perfectly fit, healthy NHS workers at home for 10 days who shouldn't be there.
Yeah, I think, Rebecca, that's the point you actually have made.
Well, yes. Well, one of the big vectors for disease, actually, I think it's a 26% of daily cases are actually caught in hospital.
Yeah.
So hospitals are divided into green channels, yellow channels, and red channels. Now, green is if you're going in as an outpatient or with an elective procedure and you've had your PCR test before you go in. The yellow is for acute admissions where they don't know the status. And then the red is where they do know the status and they're going straight onto a COVID positive ward. It's the yellow zone of the hospital that causes the problem because you're putting unknown status patients into that zone. And so some of them are getting COVID from others when they should have actually been in the clear zone. Jeffrey, Godfrey, I do beg your pardon, Godfrey, the one issue I do want to take with you is that you cannot compare the PCR test in the community with the PCR test in hospital. When you're discussing the crisis and the drama in community PCR, I can't disagree with you, but hospital-based PCR testing is accurate and it doesn't suffer from the false positive ratios that the community-based testing does. So the vast majority of testing is done in the community. You still need to recognize that one of the big issues with COVID and the crisis in hospitals is a combination of the infectivity of COVID plus the incubation period. It is far longer than influenza. Influenza, you are infectious one day before you get symptoms. COVID, it could be anything up to 5. So that's a significant difference. And then post-influenza, you are only infectious for about a day after you yourself have stopped getting symptoms. With COVID, it's anything up to 3 weeks. So the current protocols on self-isolation, which are members of staff tested in hospital, they have to be isolated. If we didn't isolate them, we would be infecting so many more thousands a day from healthcare workers, many thousands. There's no alternative.
Yeah, I mean,
well,
I
you
think
see, let me make another observation. I mean, I have to make another observation. We're dealing here with the most astonishing. This isn't Ebola, is it, Rebecca? This isn't Ebola. The recovery rate from this is positively extraordinary, even for old geezers like myself who are 71. The recovery rate, because I'm pretty fit and healthy and I do a lot of field walking and stuff, the recovery rate for me is somewhere in the region is 95%. And we're closing, we've got to get back to, we can't keep ignoring what we're doing. We are closing down the entire country and the economy for something which the recovery rate is 95% for old geezers like me. It's 99% for somebody of your age. Why are we doing this? We're doing this because we're worrying about numbers. We're playing with all these numbers, and we can agree or disagree on a lot of them. We agree on a lot of things. Look what we are doing. Look at the problems down there for men that's coming, untested men in prostate cancer. Look at all the things that are happening, all to save a problem which has a huge recovery rate. What's your game, Rebecca?
No, you see, the thing is that when you quote recovery rate, you are referring to the case fatality rate. If you went into hospital, your chance of dying if you remained on the ward is 17% at your age. If you then went into ITU and you have no idea and no way of predicting actually whether you're going to end up in ICU or not, you have a 50% chance of dying, Godfrey, at your age. So it's not marginally better for me, by the way, either. So this is a significantly difficult disease to treat once you go into hospital. And as I said earlier, the stay in hospital is significantly longer for COVID than it is for influenza. And the way you nurse and medically care for people who've got COVID is significantly more interventionist because of the infectivity of the pathogen. So it's almost influenza times 20 is what we're dealing with here. So because patients are staying in longer, they are sicker when they are in hospital. The crisis is because the elective procedures are being cancelled in favor of COVID patients who can't breathe and need oxygen. It's a crisis in triage, and it's a crisis created by infectivity, incubation periods, and length of stay in hospital. We simply cannot accept as a society that ambulances should be queuing up outside hospitals with people waiting for beds. We cannot have that, and it's going to get worse.
Rebecca, can I just come in here? Just a question, actually, for Rebecca and Godfrey. Can either of you explain to me where the flu has gone? Where is the flu gone?
Yes, I can. It's absolutely disappeared. Isn't it wonderful? Isn't that absolutely marvelous? Flu has completely disappeared from the statistics. I was checking them out this morning. I do this for a living. I just think it's wonderful. It must be some sort of act of God, David.
Rebecca, your thoughts? Flu, where is it?
Well, COVID has certainly overtaken the influenza numbers this season, and we had a very mild flu season this time last year. We had an extremely big one the year before. I don't know, it's a simple answer, but I would speculate that a lot of the people who died March, April, which were the early discharges from hospital, so that 47,000 who died in that period, March, April, they were what we call the long stay bed blockers. So they're 21-day plus stays. They tend to be quite sick, but over the summer months, they tend not to get influenza. So I think that the unexpected death rate in April, you could attribute to the ones who perhaps would have died now. I don't know. I'm only speculating. I'm not an epidemiologist, but that would be my answer, is that it was just an accelerated death back in March and April from a significant cohort. But, you know, society accepts 15 to 20,000 deaths from influenza every year. And so we're going to have to come to terms with what our coronavirus deaths are as well. And coincidentally, you can get both of them at the same time. So a lot of people are dying from pneumonia now, caused by both influenza and COVID. That they both coexist.
Yeah, but that's actually one of the things I also wanted just to sort of zone in for a little bit, because we touched on this at the beginning. It's trying to understand the relationship between comorbidities and COVID and death and mortality, because it is complicated, you know, and we keep being told that, yes, you know, the comorbidities are significant factor in COVID deaths, but we don't really, and I think, Rebecca, to be fair, you've also said this several times, you know, we don't really understand the exact dynamic, you know, exactly in what percentage contribution does COVID make towards a death. We don't totally know whether other comorbidities, do we?
Well, we do know some of them. So, for example, gender plays a really big role. And so men die more from COVID than women, and middle-aged men. So any male over 50 has a higher chance of dying than any female over 50. And the more severe cases are usually 62 to 65% male. So we do know that. The other thing we do know is, which is not a comorbidity, it's just a factor, it's epidemiological factor, is that Bangladeshi women are also very prone. But we also know from studies that go back from, you know, when I was doing renal dialysis, that hypertension is highly resistant to treatment in the Black and some of the Southeast Asian communities. Now, you may recall in the early days, a lot of the narrative was about the ACE protein, the spike protein. Well, the angiotensin converting enzyme is what antihypertensive treatments are. And we do know that BAME people are more resistant to angiotensin converting enzyme drugs. So we have to give them higher doses to achieve the same effect on blood pressure. So there is a belief that the angiotensin system does suffer considerably when exposed to the COVID virus. So the other one is obesity. And so people kind of, as a shortcut, use the word type 2 diabetes, but type 2 diabetes is a symptom of obesity. So it's better to refer to it as obesity. But obesity creates so many other comorbidities like clotting disorders and breathing disorders that it's very difficult to tangle out how COVID creates a higher death in people with a BMI over 30.
But sorry, Godfrey, just going to come in a second. Just one sort of follow-up question. You've just said, Rebecca, that, you know, COVID is particularly virulent and dangerous amongst the BAME community, the Black and ethnic. So answer me this: why is Africa not ablaze with deaths? Because it's not. Why is that?
I can't comment on that. I can't comment on whether it's the antihypertensive drug itself that causes the problem. I'm not sure that I have much confidence in the ability of many African states to monitor disease in the way that we do. And just like I wouldn't trust a single number that came out of China at the moment, I'm not really sure what the monitoring is. But if I look at India, for example, of course, as you know, David, I grew up there, and many of my friends are doctors in India, and they speak to me regularly. I know that there is a complete absence of testing in India. They just do not have the tests available. So the doctors there are testing the live rather than the dead patients. So a lot of people are dying from unspecified pneumonia and respiratory disease without knowing their COVID status in India.
Godfrey, do you want to comment on that?
Well, Yeah. I mean, this is very interesting indeed, because what we're doing now is we're moving, and quite rightly we should do, as we come to the last quarter of this very enjoyable and informative, I think, for everybody, discussion. We're now moving into the implications of the immune system, aren't we? And I think we need to be looking at that very much more closely than we ever have been. Now, what I'm very disappointed to know, because I got friends at very sharp end level on this, very senior friends at the sharp end level, there is no system for testing or standard protocol for testing whether there is any vitamin deficiencies in people who are suffering from COVID. So that's another very serious issue. So you're talking about, as Rebecca probably will already know, obviously, your zinc, your B12s, your magnesiums, and all the other things that go towards your immune system. And since the very beginning of this, in March, there has been no mainstream media or political talk seriously about our immune systems. Yet we know from the testing systems, and I very much take the point that Rebecca has made, that the punters in the street being tested, it's Mickey Mouse, and it's very much more different when you come into the hospital, and I accept that. I wish Boris Johnson would accept that, and Matt Hancock would accept that, but they don't. But what we need to do is be looking and to be getting more immune system situations. And we also know that BAME people, we know, don't we, that because their bodies were designed, as it were, for want of a better expression, their bodies were designed for a completely different climate. And so their manufacture of vitamin D and vitamin C's and their dietary systems are completely different. None of this has been discussed. We're now 9 months into this. We're 9 months into this, and nobody's discussing the elephant in the room: diet, vitamins, weight. You can be classified as perfectly healthy and died of COVID. You'll be 22 stone, but your record at the GP reckons you're healthy. There's all this kind of thing. None of this is being discussed publicly on public sector service radio, so on and so forth. And this is where we're going wrong. And yet we've locked down the whole country, ruined academic children's education systems, small businesses, middle-sized businesses. We've done all this without any serious, and I'm a professional at this. I used to do this for a living. This is laughable. If anybody came to me and said we were going to do this, this, and this with this kind of research, they'd be sacked immediately. When my old life insurance company, they'd be out of the door.
The truth is that the survival difference, say on vitamin D, which is what is relevant to BAME, particularly Black communities, actually more than any, they do not synthesize vitamin D the same way as a white person does, because they've got the melanin in their skin that protects them from the sun. The survival difference is 2.7% on that vitamin D study, and they have studied it. And actually, it is our government policy, by the way. If you live north of Birmingham, you should be taking vitamin D supplements during the winter months. I take vitamin D supplements. But when you say immune system, Godfrey, it's very easy to be very generic about the immune system. One of the reasons why COVID, they believe, has zero mortality in the under 50s, it's not quite, but it's as good as zero, is because of T killer cells. And your T killer cells are huge in number when you're born, and by the time you're 2021, they are sort of fading away. They are designed in the system to protect you from all new things that you are exposed to as a youngster. Now, you and I are more reliant on our antibody recognition system and prior vaccination in order to have conferred immunity. Now, antibodies are so important, but I have never, ever seen a study that links ability of an antibody to attach to a spike protein based on how much vitamin D you have in your diet. I've never seen it. And I would be really welcome for you to show me one. But immune system is such a generic thing. Your mental health can affect your immune system, but that doesn't actually mean that viral coding on your antibodies has anything to do with what you eat or what you take in your mouth. It's all about your congenital ability to produce antibodies to a specific piece of DNA.
Yes, but if I can come in this one, Godfrey, just for a second, Rebecca, on the immune system, if we talk about the primary immune system that we have, or innate immune system, right, which is a primary defense, two of the things that help us in terms of our immune health is, if, like Godfrey says, and you've suggested as well from your biography, you're a very active person, exercise is very good for your immune system. Getting out in the fresh air, getting a bit of sunlight is good for your innate system. One of my problems throughout this has been the government locking us up, making us shelter indoors so that we can't, I can't exercise. Well, I can't swim. Swimming pool's closed. We're being told stay indoors or the police might have to have a word with you. So it does seem counterintuitive that you tell people to do something which compromises their immune system and leaves them vulnerable to a virus which attacks their immune system. What's the answer?
Well, I wouldn't. I would kind of agree with your conclusion, but I wouldn't agree with the hypothesis that led to it necessarily. One of the problems with lockdown is that you are actually forced into communion with people far greater. And I hope Godfrey can help me on this point. I understand that the K value of COVID-19 is actually quite low, and you can sleep in a bed next to somebody with COVID and not get it. It's not that communicable in the community. But yes, you're right. When you're creating a lockdown where, say, for example, all your greengrocers are shut and it's only Tesco's, everybody's going to go to Tesco's. So it's kind of counterintuitive. So I do agree with your conclusion that we are concentrating everybody, and I can see that is one of the failings of lockdown. By the way, Godfrey, I was one of the most skeptical lockdowners going. I really, really was. But it's only the hospital numbers and the strain on the NHS, for all the reasons I think we can agree on, that I have become a little bit more tolerant of the theory of lockdown. I am totally intolerant of the way it's done. And I think Boris Johnson has shown himself up terribly badly, particularly over this weekend. It's embarrassing the way the government messaging is. And you and I can agree, I'm sure, that the way they infantilize data only encourages people like you and me to point the finger and say, you're a load of idiots. We don't believe you.
I agree, and I take your point, and you make it so charmingly, it's difficult to disagree. You did ask just a little bit, rewind a little bit there. You said, can I show you any dietary implication of immune systems and so forth? And that was a very fair question. And the answer is, of course, I can't. Isn't that terrible that I can't? Shouldn't I be able to? Shouldn't it be a protocol, a natural procedure, automatically in the National Health to check whether there are deficiencies at any form in the immune system, perhaps by a vitamin deficiency of some description? And the answer is, I can't. And that's appalling. We're learning nothing 9 months in, and we've learned nothing. It's terrible.
Well, I actually, it's funny you say that, because there was, buried in the depths of the archives, there was a really good Science Now or Science Today on the BBC. It was only a podcast. It wasn't on the main broadcast. And it was one of the professors of respiratory diseases in the US. I think it was John Hopkins. He did research on humidification of air and the survival of the virus, because of course we saw the virus drop off in numbers over the summer, and the air is more humid in the summer. And he was saying that the humidity assists with you effectively swallowing the virus, and all of your mucous membranes in your nose and throat, just with water in the day and the humidity in the air in the day with the additional heat, it makes you swallow the virus, which is why we began to see in the warmer months that the virus was presenting itself as diarrhea and vomiting. It was creating these inflammatory responses in people's digestive systems. And what he was saying is that any responsible government would recommend that people had air humidifiers during the winter months, because like you're saying with diet, I think it's not the total solution, but if you can put small interventions in, they only improve upon each other. And we have to do maybe lots of little things to improve our overall risk of not succumbing to it. Because when you succumb to this, it's a shitter of a virus. It's going to make you poorly.
Yeah, actually, Rebecca, just a quick question I saw on the stream. I have to ask you this one. You said that you could sleep in bed with someone who would have the virus and not pick it up, but at the same time, in NHS and NHS wards, we need extra space between people with the virus. How is that not a contradiction in terms?
I was merely quoting the K value, only because my son, who is an economist, as you know, he was having a row with me about it. And he said, forget R value, it's all about K, which is about transmissibility. So I was just throwing that one out there. And I was just saying lockdowns encourage you to be in closer confines with people than you normally would. But yeah, I see you've put up a question. Can we talk about masks? Do they or don't they work? You know, again, I actually think, and I think this is a highly controversial area, I think masks is more about behavioral science than real science. Pardon me if you're a behavioral scientist and you don't like that characterization of behavioral science, but I think that the behavioral scientists believe that if you wear a mask, you're more aware of space and more aware that there is an urgent problem at the moment. I think I've said to you before, David, when I was doing hemodialysis back in the AIDS epidemic, we took a decision not to wear surgical gloves because of the needling technique for dialysis. We decided as nurses that we were safer when we could feel absolutely everything, and we were less likely to pinprick ourselves with an AIDS infected needle, and that would have given us AIDS or even hepatitis. Yeah. So, you know, counterintuitively, we didn't feel we were protecting ourselves by reducing our ability to feel things sensitively. Masks, they don't work. They don't work at stopping the virus. They may work at slowing the virus down, but even surgical masks worn by surgeons are not intended for the purpose that people think. They are to stop surgeons spitting on your wounds. I'm so sorry to say that, but that is really what they're for.
But this is the strange thing, Godfrey, isn't it? I mean, I agree with everything Rebecca's just said about masks. I'm sure you do as well. And yet, wearing a mask, I mean, you know, you could be criminalized if you don't wear your face mask. Why is that?
Well, Rebecca's Rebecca's been a bit cruel to behavioural scientists. Of course, the government have been very careful to listen to behavioural scientists, because they say if you get people wearing masks, they are then used to being subservient to government diktat. This is what it is. It's nothing. I've never met a single medic who thinks that wearing face nappers is going to do the remotest bit of good. It's laughably stupid, which is why at the beginning in March they said it's a waste of time. It doesn't work. Everybody knows, who's an expert knows, that masks don't work. But what the behavioral scientists will tell you is that when people are wearing it, they will realize that they must do as they are told.
Yeah, and that's one of the big problems for me in this, because, you know, as a nation, we want to be able to get through these things collectively. But what I find is that the mask wearing is very divisive, and it sets off emotion. I mean, I've not worn a mask. Rebecca knows this. I refuse to wear a mask. I will not be muzzled by any government, unless in particular circumstances. So, but, you know, I see the look in the eyes of those who do have their masks on. And some of them, I think, are virtue signaling them. Others are probably scared witless. It's a tragedy the way masks have been introduced into this, don't you think, Rebecca? Because in a way, they've distracted us from maybe the more important things.
It's completely constipated science. It's sclerotic in its thinking. Yeah. And it's an intended consequence that somebody aged 23 has thought about, having just got a master's degree in behavioral science, and there's only one way, and it's that way, and they can't see all the unintended consequences of it. And as I alluded to earlier, this infantile way the government treats us with 3-word slogans, it drives me up the wall, because like Godfrey and you, and I'm sure everybody on this stream, I want grown-up numbers, I want grown-up discussions. I'm quite happy to accept a level of death in society from a pathogen that none of us knew about over a year ago. I'm prepared to accept that pandemics exist. But when you start introducing crap science, people do push back. And then some people will tend to lean towards a conspiracy theory, which actually is emotionally deeply damaging for people, and that's not good for the mental health of the nation. So we're creating all these unintended consequences from one bit of do-gooding. There are masks lying everywhere. They should all be in biohazard bags. If you think they're holding on to viruses, you shouldn't be allowed to throw them away in a normal bin, because if they are a reservoir of virus, you're infecting the person who collects the bin. If it's really a problem, but it isn't. It's about behavior changes. But I'm afraid the law of unintended consequences, which is what common sense of the common man is it's a pile of crap, and we know it's a pile of crap. We're just doing it to make other people feel good. We're not doing it to prevent infection vectors. Absolutely not.
And that I'm sure you'd agree with that, Godfrey, that mask wearing it's not helpful probably for anybody that I can think of. And yet, as Rebecca says, Godfrey, 3-word slogans, a little bit of ritualistic hand washing, social distancing, and mask wearing, that's going to save the day. And it's not, is it, Godfrey?
I agree with absolutely everything that Rebecca's said. How disappointing is that for everybody?
Well, we seem to have an outbreak of harmony, which is...
I would disagree with you, David, because hand washing does work. Hand washing...
You are right. Yeah.
Hand washing is very simple. And you know what? I was at the beginning of the lockdown back in March. I was such a big advocate, because I was saying we must persist in hand washing and social distancing, keep people at a distance. I used to kiss everybody, frankly, in those days. I did greet people with, the old French kiss. But, stop doing that. Stop going into crowded places and wash your hands. Simple, simple techniques. We have not given a single policy time to work. And so we didn't shut our borders to Wuhan. We didn't do the right things at the beginning. And this bloody government has been playing catch up ever since. And their policies are getting more and more bizarre and aberrant by the day.
Rebecca, I've been asked this multiple times, so I'm going to ask you this one. What is the number of deaths that you would accept with COVID so we can have our freedoms back? I've been asked that multiple times. What's the number?
Well, as I said earlier, we accept 15,000 influenza deaths every year. I would have thought that, I'm just guessing, right, because I haven't prepared that answer, but I would say that our society would tolerate total seasonal respiratory deaths to be in the 15 to 20,000 every year. I think that is going to be a fact of life. And when we've got, wide scale herd immunity through either vaccination or prior infection, I would expect that we will see 15 to 20,000 deaths every year. This virus isn't going away. It's here.
I think, Godfrey, back in, was it 2018, 2016, we had, was it 60,000 deaths from flu? So, we didn't lock our society down back at that point with that number of deaths. So why should we lock it down for COVID?
I would accept absolutely no house arrest, lockdowns, policemen asking me if my journey is really necessary, compulsory face muzzles, we must go our own way. We are all going to die one day. Every single man jack of us is going to die one day. And if you're really frightened, if you're really worried, wear your mask, hide under the stairs, send out to Tesco for delivery. Don't ask me to. I'm 71. I've had a belter of a life, and I want my freedom back. I don't care if I'm stepping over dead bodies in the bloody street.
Do you care if you get COVID, though?
Not one jot.
You'll die.
Well, on that, okay. I think, Rebecca, to be fair, I mean, there's a lot of people. I've spoken to people. Godfrey, at 71, you know, you're still quite a youngster. I've spoken to people considerably older than you, people in their 80s, late 80s, and they take the kind of same view that you do. They figure they've had a good innings. They want, in particular, they want to be able to, you know, hug their grandchildren, be close with their families. They don't want to be locked away. And if the price of that means that they get COVID and die, so be it. And, you know, I've heard that from people of that age group, so a lot older than you, Godfrey. And they're also taking the view, Rebecca, that, you know, look, life is for living. It's not for hiding.
Indeed, but you know, I don't think we can forget that 650 healthcare workers have died, and now none of them would expect to die from an infection they get at work. So I think, you know, it is different. There are lots of different aspects to it, but old people do die from respiratory diseases. And, you know, we have seen an atypical pattern this year that people normally don't die of those seasonal respiratory diseases outside of February. And in April, we saw, you know, quite a big surge of this atypical pneumonia. So this is going to be a background level forever now. And vaccination is just going to have to play catch up with COVID.
Well, you know something? I mean, life, unfortunately, death is a part of life. And we have to live our lives. We have to be sensible as well. But what I would say to you both is this has been a really enjoyable conversation. It's been pleasing to see so much commonality despite some points of difference. And I guess for me, folks, and all of you watching this is where a channel like this actually is a benefit. You can have a civilized conversation. Godfrey and Rebecca agree on some things, disagree on other things, you know, but it's all been, I think, approached with an enlightened attitude. And that's really helpful. And I know that I've seen all your comments, so I see all that's been said, but I've enjoyed it. So Rebecca and Godfrey, I want to thank you both very much. Thanks for taking part in this one tonight. That's it from me for tonight as well. Folks, thanks for being in the stream. I see the numbers are very high, so that's great. And that's testament to Godfrey and Rebecca. So look, thank you all very much. And of course, Open Dialogus returns tomorrow night with Bill Etheridge's one-to-one interview series kicking off. So I hope you tune in to watch Bill tomorrow night. But that's it from me, Rebecca and Godfrey.